You're all set?
Okay, so my poster is on self-harm, you viewing it through an evolutionary lens. So self-harm as a concept stands right in the face of evolutionary psychology, which is all about the survival of the fittest and the adaptation of behavior that is not detrimental to human behavior. But self-harm stands as a paradox because it is something that does not help us survive, but has still gone through and evolved through generations and is widely rampant between cultures and different age groups. So evolution sees self-harm as a communication and signaling behavior, the signals being either cheap or costly. So right now we're discussing cheap signals because they don't lead us to have any personal sacrifice. It's not costing us anything. So talking to each other is constituted as a cheap signal. But if after a point I believe that what I'm saying is not getting across, I might switch to a costly signal just to communicate the depth of what I mean to say. So it has been seen as a cry for help in evolutionary psychology, where people try to communicate what they're feeling through a costly signal, the cost being self harm and detriment and harm to yourself. My study views the antecedents to this self harming behavior, and the antecedents are guilt and redemption. So, there's a very long body of research which states that guilt is something that triggers self harming behavior. Although there is also a body of research which states that people engage in self punishment only when they feel that they can't compensate for their actions. However, these studies on self punishment focus more on social settings and a self denied pleasure rather than physical pain. So, my study aims to bridge this gap between the studies done on guilt and the studies done on self punishment. And I want to see whether this self punishment effect, which is interestingly being called the Dobby effect, which just means that individuals would be willing to hurt themselves or self punish themselves if they feel that they can't compensate for their wrong actions. So I want to see whether this Dobby effect translates to a physical aspect and the self harm aspect. So my study has the hypothesis that guilty participants who are given the chance to redeem and compensate will be willing to endure less pain than those who are not given the chance to compensate. So the procedures, if you've read them by now, go like the participants are divided into two groups: the apology or the non-apology group. They're all asked to write about something guilty, something that some an incident where they feel like they wronged somebody, that an incident about which they feel guilty. So all the participants in both the groups, in both the conditions, they write about such an incident, and then they're asked to fill the positive and negative effect scale. After which they after which the apology group is asked to write about how they can make up for their actions, and the control group is just told to write about something which is neutral, a neutral event. After this, they're all asked to go through a pain manipulation, which is basically a pressure algometer eliciting pressure on your index finger. And I am aiming to see how long they would be willing to endure that pain of the pressure algometer exhibiting pressure on their index finger. The hypothesis being that participants who got the chance to redeem for their actions would be willing to endure less pain than the participants who did not get that chance to redeem for their actions, because redemption is something that has been set and imbibed into our society when we look about it. If I had to give you an example, if we see at our current law structure, if I, for example, do something wrong or do something illegal, I would be sent to jail where I would redeem, a jail which is looked upon as suffering. So I would suffer for my guilty actions and redeem for my actions, which would alleviate me of the guilt. So the theory is that guilt can be alleviated through redemption, which is compensation, and then individuals would tend to not engage in self-harm. So the overarching goal of the research is that if this finding is significant, if I indeed do find that participants who could redeem for their action were willing to endure less pain, I would move on to help designing an intervention for individuals who go through the addiction of self-harm by going through the root cause, and first of all by psychoeducating that this is it, because it stands as a very confusing thing of why you would even take a detriment to yourself and hurt yourself. But I would help, I aim to help design an intervention where individuals who are facing this addiction can know the root cause of why they engage in this behavior, help them find what they're feeling guilty about, and then the intervention could lead on to resolving this root cause of guilt. Not only that, it could also promote community service and other pro-social behaviors that could help individuals alleviate their guilt and in turn reduce their self-harming behavior. So that is the gist of it. Gist of it. The floor is open for questions, if any. Thank you so much, Catherine. A little that I see that little emoticon. Thank you so much. I'd love to answer any questions if any one of you has some.
Feel free to come off mute and ask your questions, or feel free to put them in the chat and we'll be happy to read them to Sasha.
Okay, I'll wait for you to put it in the chat if you do have any questions. But apart from that, I would like to discuss the background of this study. So this study is something that is this is actually my thesis, and it is something that I've been working on since the past year. And we're currently trying to get it through the IRB procedures. And these are anticipated findings, and I hope that I do get to collect the data and actually get to conduct this research, because I believe that it is something that could really help a vulnerable population, because the adolescent age group is the age group that suffers the most from self-harm. And they are, whenever I talk to, so I've worked with a lot of mental health counseling clinics, and whenever I talk to somebody who's actually going through the addiction, they're very confused about why they're actually doing it. So I've talked about the evolutionary aspect, I've talked about the contemporary times, but there's also a theological aspect, and there's also a biological aspect. The theological aspect being that harming and redemption to alleviate your guilt is also something that is imbibed in religions, in Hinduism, in Catholicism. Self-flagellating and repenting for your sins, it is something that is also an integral part of a lot of cultures. And I think it is, self-harm is something which is uh, a socially non-acceptable form of self-harm, but there are also a lot of other forms of self-harm that are self-harming behavior, but they're just socially acceptable. Examples could be excessive gymming, excessive drinking, excessive working. I see a doubt by Catherine.
I'm sorry, I didn't mean to interrupt you. I'm also going to apologize if you can't hear me well. I'm at the undergraduate research conference right now too. But I know you were talking about this idea of there being high versus low level attention grabbing behaviors, the idea that self-harm is kind of that high cost version of getting a social response.
Right.
So I guess I'm curious on just more of a theoretical level, maybe a little bit of a social psychology perspective. What is it about engaging in self-harm behaviors that is then prompting that response from others? And what's the social benefit of essentially providing that attention or a response in that way?
So this is the evolutionary point of view of it, where self-harming behavior is seen as a costly signal. So it is just that when individuals see other individuals engaging in an act that is detrimental to themselves, it calls for attention. And this can be seen in a negative and a positive light. I think that depends on how you're viewing this very concept and this very theory. But it is seen as a cry for help, where a lot of individuals actually going through this feel like, I don't want to I don't want any attention, I don't want your help, I'm just going through something and this is my coping mechanism. However, evolutionarily, when you do this, it is when you're trying to communicate, not through words, but a cautionary signal that I'm not feeling well, I can't do this. It's when your parents start to notice, it's when your partner starts to notice, it's when society starts to notice that you're not okay, and that's when you start to get help. So I don't know if there are social benefits, but it's something that's a cry for help. And the biolutionary aspect of it is that the biological aspect is that people don't get addicted to actually self-harm. It's the rush of endorphins that goes through your body when you hurt yourself, and the endorphin rush is what you get addicted to. Hope that answers your question.
Yes, thank you.
Thank you so much. Thank you so much. I think I'm on time. Well, thank you so much for the opportunity, Chris. It was lovely presenting here. Thank you so much, Aisha. I see your.
Thank you so much. All right. So next we have Tiffany Blanco. Sasha, if you want to stop sharing, and Tiffany, you want to put your presentation up? All right.
I'm pulling it up now.
You're good.
Can we see it?
It's a little small. You might want to make it a little bit bigger. I don't know if you can.
I can, I don't know if I can either.
Okay, why don't you put it in,
Try.
yeah, why don't you put it in presentation mode?
Let me see if
And
that's
then you can
helping.
probably speak to it so other people can see it. So, okay, I am gonna start the timer and then we'll get going.
Thank you. Okay, so hi everyone. So me and Carmen are here today. We also had other people in our team. So Ashley, Nina, Carmen, and Danielle and Helen who aren't here today. But our presentation was caregiver perceptions of functional use of nouns in preschoolers with autism spectrum disorder, compared between sexes. So what we're first going to talk about is that autism spectrum disorder is a neurodevelopmental disorder. So this disorder impacts domains such as pragmatics, semantics, syntax, social communication skills, and other areas in comparison to typically developing peers at their same age. So what this means is, so children with autism spectrum disorder, they can present with weaker vocabulary sizes compared to typically developing children. And research shows there's like a suggested delay word learning. So with their lexical composition, there can be language delays and there can be a variation of their vocabulary skills. So what's interesting about autism spectrum disorder is that it's more commonly diagnosed in males rather than females. So the ratio is 4:1. So due to this, there's a larger male sample size in the majority of autism spectrum disorder studies. So this leads to the literature gap. So what research shows is that females actually what we call mask or camouflage their symptoms. So what this means is that they present more typically or superficially in social interactions. So they have more positive social behaviors, but they do lack that true social connection that we make, like when we're meeting people and things like that. So autism symptoms are more apparent in males than females. So this again leads to that females should be researched more thoroughly and compared to other females to gain more an effective like diagnosis. So it does lead to our research question, which is how does the caregiver's perception of the functional use of nouns in preschool age children diagnosed with autism spectrum disorder compare between sexes? So again, going back to the contribution to literature, I'm so sorry. There's a gap, like what I was saying before. So the aim for our study was to dive deeper into this gap between males and females on the spectrum. So as I said before, more males than females receive a diagnosis of autism spectrum disorder. So they are participating more in these research studies. So again, we wanted to seek
and examine these gender differences in expressive language to determine the reasoning behind these gender discrepancies in autism spectrum disorder diagnosis. So as females are more typically overlooked than males due to their camouflaging and their masking, the study was to demonstrate the importance of research to get more accurate diagnosis. So for our methods, our participants had to follow the criteria. So they had to be 18 years of age. They had to be a parent or a caregiver of a child whom had to be diagnosed with autism spectrum disorder. The child also had to be between the ages of 3 years, 0 months, and 5 years, 11 months, as we were looking at preschoolers. And again, this child had to communicate via spoken language at least part of the time. So our materials were just, it was just an online survey via Qualtrics. It consisted of 22 questions. So what we did is at the bottom of the poster, we had this flyer that we distributed to Facebook groups, nearby institutions. So for us, that was our Stony Brook Autism Clinic, Developmental Disabilities Institute. And after we distributed the flyer, we collected 26 usable samples. So with this breakdown, it was almost 50-50 ratio where there was 14 males and 12 females. So with our samples, we were able to analyze using an unpaired t-test to examine the differences between caregiver perception of noun usage and the sex of the children diagnosed with autism spectrum disorder. So I know it's a little small, but there is a figure on there. I wish I can blow it up to show you, but it's really just an example of what our question looked like. So our questions were based on like a Likert scale. So it was like never, once or twice, or once a month, like things like that. So a question would be, how frequently does your child verbalize words in the category of animals? And then we would give an example like cat, dog, fish, horse, and so on and so forth. Fourth, we had like different categories, animals, vehicles, toys, clothes, body parts, furniture and rooms, household items, outside things, which is like tree, flower, dirt, places to go, people. So basically all the categories that a typical preschooler would be using at the time. Yeah.
Now for our discussion, these results confirmed our null hypothesis. As previously mentioned, research has found that there is a higher diagnosis rate of males with autism than in females. The distribution of sex types across subject were relatively even, as Tiffany mentioned. We had 14 males and 12 females. So this entails that the maintenance of semantic categorical frequency across these groups may have been attributed to the diagnostic process. Additionally, females without autism are shown to have more complex semantic use than in males below the age of 6. So females with higher semantic variety may have not been diagnosed yet. Some limitations of our study include our small sample size of only 26. As well as a lack of representation throughout America and other countries, as well as a lack of consideration of noun development in other languages other than English. Clinical implications of this study are that both males and females between the ages of 3 and 6 with the diagnosis of autism are likely to have similar semantic noun variety, as well as frequency of use, as well as early intervention services can also be provided with autism for children with autism that can impact their language development as well as vocabulary acquisition. For future research, it could include potential correlations of a lower incidence of autism diagnosis in females who do have higher semantic variety, as well as to adjust the criteria to include a greater range of participants. And yeah, that's it. So if there's anyone that has any questions, please feel free to ask.
Feel free to put your questions in the chat too if you prefer to communicate that way. We'll be happy to read them off.
Hello. Again, apologies for the noise in the background. When you were introducing your background research here, I know you had mentioned the idea that we might have a higher prevalence rate in males compared to females because of a greater engagement of masking or passing as non-autistic behaviors. And I was just curious if either of you, maybe both of you, had any thoughts as to why we would see those higher rates of masking or higher rates of compensatory mechanisms that might occur for young girls compared to young boys. Sorry, that was a long read up. Why would girls be better at masking than boys?
I'm so sorry. I was trying to find the unmute button. It's like so weird. It's like in the sharing screen, I'm like trying to unmute. From what I remember from the research, they do say that females with autism, they're masking or what they call like camouflaging. They do this to like maintain their relationships or like fitting in at school. I'm not really sure what I can't give like a definitive answer as to why, but I do know that that research has talked about them doing this to maintain like friendships or their relationships, like to fit in, and they're past like trying to pass as like typically developing or what we would say like normal, lack of a better word. Yeah, so that's what I would say.
Thank you.
Well, thank you, Tiffany and Carmen. We appreciate it. Wonderful presentation. Next, we have Megan Derry from Brockport. Megan will be giving a presentation on a qualitative approach to explore college students' perception of campus food environment at SUNY Brockport.
All right, can you see my slide?
We can. I'm going to start the timer. Here you go.
Thank you. Again, my name is Megan Derry. I am a Master's of Public Health student at SUNY Brockport. I am presenting my qualitative research exploring college students' perception of the campus food environment at SUNY Brockport. It may not be a surprise that most Americans do not consume enough fruit, vegetables, nuts, and grains. There is an overconsumption of added sugars, processed foods, and trans fat. A healthy diet is a key to good nutrition and is necessary for a long and healthy life. Poor eating behaviors increase the incidence of many chronic diseases such as cardiovascular disease, type 3 diabetes, and hypertension. In the US, chronic diseases and the health risk behaviors that cause these diseases account for most healthcare costs. Unhealthy eating habits have been contributing to the increase of overweightness and obesity rates over the past few decades. About 33.8% of adults are considered obese and 68% are overweight. College students are in a stage of transition in their lives with increased independence as they have more opportunities to make their own decisions. College is a critical period regarding their food choices and their relationship with weight gain. Eating behaviors during college years are likely to carry over later in life. These years are a critical period for habit formation. Unhealthy dietary habits have adverse effects on weight status in young adults. The college environment has been labeled an obesity-causing environment due to its high access to low-nutrient, energy-dense foods and the high-calorie environment of the dorms. Obesity is a serious health risk that has an incidence rate of 29% among people aged 20 to 39 years old. Studies show that college students tend to gain more weight than those who do not attend a college or university. Only 7.3% of college students eat 5 or more servings of fruits and vegetables daily. Time spent at college can be recognized as an important phase to promote students' health and prevent diseases. So the purpose of my study was to utilize qualitative measures to explore student perceptions of college campus food environments and identify methods that can improve healthy eating. The primary research question was that explored is what methods can be put in place to improve healthy eating habits among college students. This study utilized a purposive sample of college students at SUNY Brockport. Study eligibility was limited to full-time students who were currently enrolled in in-person classes. So therefore, students who were enrolled in fully online classes were excluded from this study. Purpose of sampling technique was utilized because I was interested in selecting participants who could provide rich information on the topic of access to healthy foods on campus. The data was collected via an online survey, which was distributed by email, and each participant answered a preset list of questions in relation to their eating habits, as well as access to healthy foods in their environment. The survey was created and completed by an online survey creator, and the results were downloaded to an Excel spreadsheet. Thematic analysis approach was utilized to analyze the study data, and a code book was developed. This led to the development of themes from the data and understanding of the student perception of food access. A convenient sample of 17 SUNY Brockport students was selected and participated in the online survey, and this included 2 freshmen, 2 sophomores, 5 juniors, 7 seniors, 1 graduate student, and there was a pretty even split between students who lived on and off campus, and they indicated that they purchased food from local grocery stores, the public farmers market, or utilize a meal plan on campus. Students provided mixed reports regarding access to healthy foods on campus. They identified barriers to accessing healthy foods on campus, such as high access to fried foods, time, locations of food vendors, cost, limited healthy options, and lack of fresh produce. All students reported access to healthy foods off of campus. However, some barriers identified was cost and knowledge of how to prepare balanced meals. Students again provided mixed reports regarding whether the college environment is supportive of their ability to eat healthy nutritional foods or not. There was one student who expressed, and I quote, "I feel that college environments require students to live off high sugar, high calorie energy drinks, and easy prep but highly non-nutritious foods such as instant ramen, just to have time to eat." And this quote aligns with barriers for healthy eating reported in similar research studies. Another student reported that they feel there are healthy foods available on campus sometimes, but a lot of them are have high levels of sodium and cholesterol. There was agreement among students that there are limited healthy options offered on campus, and these foods are lacking freshness and are overpriced. The students suggested a variety of methods to improve the environmental support for healthy eating, including class schedules allowing for more time to eat lunch, incorporating lean meat and low sodium options on campus, improving knowledge and offering resources on how to cook and build nutritious meals, improving cost of healthy foods, providing more easy and convenient healthy options, having healthy snack stations in various buildings throughout campus, giving students more time to allow for healthy eating, and accepting SNAP benefits on campus. Some recurring themes included the need for increased variety of healthy options on campus, improving the cost and affordability, offering education related to a healthy and nutritious diet, and allowing for the time to incorporate healthy practices into student schedules. So this study revealed insights into students' thoughts about healthy food, their access to it, and what could be improved upon to better support their well-being. These barriers identified aligned with those identified in similar studies. The study also identified areas for opportunity where universities can implement strategies to improve the eating patterns and health of their students. This research can inform policymakers and program inventors and present as a guide. Interventions that can be concluded from the study based on student perception included improving the affordability and number of healthy food options, including lean meats and produce, offering programming to teach students how to prepare a balanced meal on a budget, prohibiting classes during the noon lunch hour, and improving the quality of easy and convenient food such as in vending machines. So hopefully the study has potential to be the basis for future research and lead to future studies and efforts that seek to address healthy eating among college students.
Megan, I figure I will continue on my path of asking questions. This is really great. And I think looking and hearing your results here, a lot of these suggestions feel very intuitive, right? So I think as you list them out, many of us are likely sitting here being like, of course, there should be fresher produce options. We should have more time in our schedule for this. So I'm curious if just maybe as part of your background research, you came across any of the barriers that would prevent implementing some of these suggestions at either the college administration level or maybe even at a broader state policy level, given that we're all part of SUNY here.
Yeah, so I definitely think, one of the limitations of this study was that we really focused on just the environment when there's plenty of other factors that are influencing someone's ability to choose or be able to eat healthy. So I think one of the main barriers is probably from the university level in implementing policy, especially around the cost and affordability of healthy foods. But I think, that's not just the university. I think that's just the community and society in general. So that'd be a much larger undertaking than just the university level. But I do think that would probably be one of the top priorities, is implementing a policy to help with just the overall cost of food and especially healthy foods. In terms of what their barriers to doing that is probably, again, at a larger scale, how much it's cost them to bring in that food and provide it to students, and charging them an equal higher cost for that. So I think it's more so looking at it from even bigger than the university level, but society as well.
Thank you.
Thank you.
Any other questions for Megan? Okay, well, thank you for your presentation, Megan. It was wonderful.
Thank you.
Okay, so next up, we have Erica from Brockport as well. Erica will be presenting on social media and stress among college students, a qualitative study. Go ahead and share your screen.
Sorry, it's just taking a second.
Okay.
Okay, is everyone able to see it?
Yes, we are. Okay, so I will start the
Okay.
10-minute timer for you.
Great, thank you. Okay, hi, my name is Erica Alsison. I am pursuing my master's in public health at SUNY Brockport, and today I will be talking about social media and stress among college students in a qualitative study. Social media and its impacts on stress and anxiety are not a particularly new association being identified. There is a strong body of existing literature. In fact, existing research has identified pretty significant and strong relationships between social media and multiple symptoms of mental health struggles, including stress, anxiety, depression, loneliness, decreased empathy, impaired self-esteem, and even suicidal ideation. A lot of this does relate to the fact that college students are a population that is particularly vulnerable to these types of issues. And that can be highly attributed to the being in a transitional period of life, whether that means moving away from home, adjusting to the college course load, in some specific cases, adjusting to college athletics, or just simply being in a new environment. Those are all very high factors for promoting anxiety. And that contributes a lot to college students being a particularly stressed and vulnerable situation. Existing research has identified that college students utilize more than 5 social media platforms on a daily basis. And the big difference between these different platforms is what they are utilized for, whether that is communication, entertainment, or some can even be related to academics. Going into some of the existing literature on this specific topic and how it relates to stress, significant relationships have been identified between emotional investment in social media and risk for developing anxiety. In other words, that means that it has been identified that the more a student is invested in or really cares about social media and its role in their lives, they are at a much greater risk for developing anxiety in relation to its usage. Furthermore, other strong factors to be considered are that social media has been shown to impact sleep deprivation among this population that may already be severely struggling with this issue. And finally, another key factor to consider is called FOMO, or a fear of missing out. And that is something that, again, has a lot of accessibility for college students in terms of increasing their anxiety. The objective of this study specifically was to assess how social media usage impacts stress levels of undergraduate students, a population that is known for manifestations of excessive stress. Going a little bit into the methods section, this was a semi-structured group interview that was completed via telephone. These students were identified via snowball sampling of the population of undergrad students at SUNY Brockport. The study population became 14 of these undergraduate students, split pretty evenly between male and female and dispersed very fairly among the different age levels. This was a group phone interview with a guide. The questions were posed from the guide to the students, but they had a lot of freedom in terms of how in-depth they wanted to answer. The telephone conversations were recorded and converted to written transcripts, which then thematic analysis was utilized to identify common themes or recurring ideas across the transcripts. Some of the key results included that the primary reason for regularly using social media was entertainment. And this was something that really stood out to me because entertainment is something that is generally thought of as being unimportant in terms of social media usage. It has a much more positive connotation to think about social media as being good for connection and keeping people in touch with long distance family members or friends. But I found it particularly interesting that entertainment was the one that I was identified most. Another common theme was that many students classified their social media usage as sporadic, meaning that they didn't feel that they were using it constantly throughout the day. A lot of them mentioned that they used it when they first woke up in the morning, during lunchtime, between classes, or in the evening, unwinding from their long day. Very few felt that they were addicted to social media usage. Almost everyone felt that they would be able to completely halt their social media usage with little to no trouble. However, there was a common idea that they didn't want to or feel that they needed to do that for their own mental health protection. A key idea here was that social media, they felt it impacted their mental health both positively and negatively. Some of the positive impacts included that they felt it improved their feelings of connectedness to family, friends, or peers who they might not see on a regular basis. It increased a sense of belonging within the community of individuals they have met on social media. And it also provided an outlet from stressors, which relates back to the idea of entertainment being the foremost reason to use social media. The negative impacts included that social media damaged body image, promoted jealousy, and encouraged a feeling of missing out. And in weighing these positive and negative impacts, there was a resounding answer that many felt the harms did not outweigh the benefits, especially to the point that they didn't feel they needed to halt their social media usage for the purpose of protecting their own mental well-being. The results of this study were able to lead to the ultimate conclusion that undergraduate college students do not feel that social media impacts their ability to be mentally well. This is slightly different than the existing literature, which has identified that strong association between social media and stress previously. However, this suggests a good idea for much further research, including whether the impacts vary between social media platforms, whether major or extracurricular activities may be playing a role, as well as, as well as whether age of initial social media usage might be playing a role in this as well. The key limitations of this study include it being a small sample size and non-random sampling methods as snowball sampling was utilized. However, I think this creates a very strong jumping off point for further research as previously mentioned. Some of the things that I would be more excited to pursue on this topic in the future would include those that I previously mentioned, but I do think that this creates a strong overall feeling that more research is needed on the topic. Thank you. Are there any questions?
Hi, Erica. You already know I have one. So one of the courses that I teach frequently on our campus over at Farmingdale is research methods. And so we encourage students to come up with their own research questions, design their own studies, and collect data. Inevitably, out of the 5 to 6 groups I have each semester, at least 4 look at some form of an impact on social media and mental well-being. So I have students that are interested in stress, students that are interested in things like self-esteem. And what's really interesting is that whenever they're forming their hypotheses, they always assume there's going to be a negative effect. And then because of small sample sizes, all these other factors, they generally don't find anything. But I think what really struck me about your work here is that you have students that are reporting they're aware of the negative impacts of social media, but then they're also self-reporting. It's almost as though those impacts don't apply to them. Right? This can be bad for some people, but when we're talking about our own experiences, maybe not me. And so I was curious if you had thought about any other forms of measurement outside of self-report that might have a little bit more of an objective perspective, and maybe doesn't require undergraduate students to be as self-reflective as some of these self-report scales do.
Yeah, absolutely. That was something that I found really interesting too, because I do think it becomes one of those things to be very easily thinking, oh yeah, it might not be bad, but it's okay. I'm not going to fall into that group. I'm not going to let it impact me that much. So not necessarily objectively, but I think one thing that could be really, really beneficial with more time and resources allotted to this topic could be setting up some sort of system where the students aren't individually reporting their social media usage, but rather have to maybe show proof of their screen time usage throughout the week and finding when those times are throughout the day that they might be using it most. And then from there, asking them for a couple days, maybe a week or a couple of weeks to kind of do a self-reflection of, oh, I'm going to open a social media app. How am I feeling at this moment specifically? And maybe a Likert scale or something of very low stress present, very high stress present, and then further going into that, oh, is this because of something? Do I have an exam in an hour? Do I have an exam tomorrow? Ask them how long they use social media for in that one sitting. And then after that, ask them to complete the same sort of scale-like question of how am I feeling with my stress at this moment? And so I think that would really do a good job of looking at the short-term effects, as well as even figuring out if they are aware of that in that moment.
Yeah, I agree. I think that would be fantastic. I know the timer is going to go off in 8 seconds. But the other thing I found funny too is they all reported sporadic usage when they woke up, during lunch, in between
Yeah,
breaks, before.
I agree.
So thank you. This was wonderful.
Thank you so much.
Wonderful presentation, Erica. Thank you so very much. Next, we have Sharon Wong from Stony Brook, along with Kelsey and Isabella.
Yes, thank you. I will share the screen right now, and Isabella and Kelsey will be taking lead on presenting.
Okay, perfect. All right, I will start the timer.
Alrighty. Sorry, pardon the noise. I'm in the library and there's a child that is crying right now. So sorry. Okay, yes. So our research presentation is about the knowledge and perceptions of the general public regarding the scope of practice of speech-language pathologist. Our group members were Cindy Chang, Susan Chen, Sharon Huang, Kelsey Lewis, myself, Tiana Mosley, Isabella Pampolonia, and then we have our research advisors, Dominic Fortuno, Linda Rosalugo, and then the entire speech department at Stony Brook University. So our introduction. So our research objective is investigating how individuals' demographic characteristics influence their perception of the scope of practice of speech-language pathologists in various settings. Initially, when we did this presentation towards our classmates, we asked them to raise their hand and tell us if they've ever had to explain what they're going to school for. And basically everyone raises their hand. We find that our profession is something that is not really known to the general public. Most people just think that we work with children in the schools working on like articulation, but we work way more past that. We have something called the Big Nine, which is like the big 9 areas of speech language pathology, which is articulation, fluency, voice and resonance, language, cognition, hearing, swallowing, social communication, and communication modalities, which is not what the general public knows, especially our settings too. We don't only work in schools, we can work in hospitals, we can work in skilled nursing facilities, in prisons, and so on. So our study did a literature review, and we found a lot of literature that agreed with what we were thinking, that not a lot of people know what we do regarding our scope of practice and the settings we work in. One of the studies we looked in split participants into 2 age groups, under 35 and 35 and above. And with the results, it revealed very awareness of audiologists and speech language pathologists among medical professionals, regardless of their age. This concluded the emphasis for the need of increased awareness of what we do among medical professionals and highlighted the necessity for future education to address this lack of awareness. Another research that we found by Abby Spinko investigated public perceptions regarding SLPs, revealing that 1/3 of the participants admitted to knowing nothing about our profession. So, the speech language pathology roles are usually misunderstood. Another study in Australia revealed limited public awareness of speech pathology. Higher education levels correlated with better understanding of SLP scope of practice. So regarding our aim, our research question is, how do age, gender, identity, and level of education affect the knowledge and perception of the roles and responsibilities of SLPs employed across different settings? So we just wanted to observe whether specific demographics, which are age, gender, identity, and level education, have a better understanding of the roles and responsibilities of SLPs and the settings. And our findings may contribute to the development of interventions to improve our understanding and knowledge of SLP's roles and responsibilities, as well as to promote diversity in the field and push for services in underserved and underrepresented populations. We need to educate them about our profession. Regarding our method, so we had a quantitative study that used a cross-sectional design and was designed on Qualtrics. The survey reached 222 respondents. 135 submitted completed surveys, and 87 were excluded due to incomplete and missing data, unfortunately. So overall, we have a response rate of 60.8. Our inclusion criteria included access to the distributed survey, access to the internet and Wi-Fi, ages 18 and up, and primarily English-speaking individuals. Since our inclusion criteria wasn't extremely limited, I think it helped us be able to get 222 respondents. And then our exclusion criteria was basically anybody related to the SLP or audiology field, because of course we know what we do, so that really wouldn't be a fair judgment for our survey. And then regarding our survey, so our survey was published on Qualtrics. We used a QR code on the bottom of our flyer. We promoted the flyer just with email, word of mouth, communicating with our research advisors and having them spread it to their community, Facebook groups, social media, all over. We really try to push the survey as much as we can so we could get a good number of people, and we also wanted to get a good distribution of all 3 of the variables, so age, gender, and level education. Participants were promoted to answer 20 questions on the survey, ranging from their personal demographics, as well as their familiarity and general knowledge of the SLP profession. The survey ended with a short response question prompting the participant to ask whether or not they thought any changes should be made to the awareness and understanding of SLPs among the general population.
So
And then
for
we're gonna
our
pass it on.
results, among the respondents, 60.8% completed the survey, while 39.2% were incomplete. Demographic analysis are visualized in figure 1, 2, and 3. And there was no significant difference in knowledge. However, there is a potential effect of education level and a statistically significant interaction effect between gender identity and education level. It was 0.000907 as shown in table 1, and perception of SLP's scope of practice was not significantly influenced by demographic variables. So sentiment analysis of open-ended questions found that 48.1% were positive and 34.1% were neutral, and 15.6% were negative sentiments towards whether or not change should be made to increase awareness of understanding of speech language pathologists among the general public. Most respondents advocated for increased awareness and understanding of SLP's roles. So some limitations about our study was that the majority of our respondents, so 71.1%, were female. This disproportionate representation could skew the findings and limit the generalizability of the results to the broader population. So particularly in contexts where gender plays a significant role. Our study sample also lacked adequate representation of age, as only 5.9% of respondents were aged 65 or older. So this limited representation could skew the results in terms of age-related factors. And previous research studies found that our research findings both highlight the limited public awareness of the roles and responsibilities of speech-language pathologists, and future research using a more diverse survey population on gender and age could help gain a better understanding of its impact on the public's knowledge on the roles and responsibilities of speech-language pathologists. So this study highlighted the public's limited knowledge of the roles and responsibilities, and it suggests that education and gender can affect people's understanding of SLPs, and targeted awareness campaigns could help. Although there were some inaccuracies, the sentiment analysis indicated that people want to be more informed and emphasize the need for educational programs to bring more awareness. The research provides valuable insight that could enhance public understanding and support for SLPs while removing barriers to access for speech-language pathology services. That is it. Does anybody have any questions?
Again, if no one else does, we know I always have an endless amount. I moved, so I'm kind of in a different space now, but I'm just curious. I know you were saying that out of respondents, 40% that had started the survey didn't complete it. And then it looks like you had an overwhelming number of females that were completing the survey compared to males. And so I was wondering if you had any ideas about what might have been driving either that data loss effect or why we're seeing that the majority of survey completions are from women.
I can answer that. Oh, you can go ahead, Isabella.
Sorry. So I think a lot of our respondents were answering the multiple choice questions. I think when it got to the fill-in questions, people didn't respond to some of them. So that caused a lot of our, data not being able to be used. Sharon, did you want to add onto it?
Yeah, absolutely. So we also wanted to add that just within our group ourselves is mostly, if not all, girls and females too. So just being able to spread it amongst our friends who are not in the field, I think we're also created a bias of female participants as well.
Yeah, I
Kelsey,
thought your
did you
age
have-
findings. Oh, sorry. I was going to say, I thought your age findings were interesting too, because as soon as you said you had fewer respondents 65 plus, I was like, well, they're not scanning QR codes.
Yeah,
right?
I'm sure. Yeah, the technological aspect.
The distribution method. Yeah, but no, this was really great. Thank you.
Of course, thank you.
Thank you so very much for your presentation. Next, we have Joyce Lynn from Stony Brook. I don't see Joyce. Oh, there's Joyce. Perfect. Joyce will be presenting on examining health decision-making supports for Asian American undergraduate students. Go ahead and share, Joyce. Perfect. All right, I will start the timer.
Hi, can you guys hear me?
We
Just
can.
checking. Okay, thank you. So, hi, my name is Joyce, and I'm presenting a research study I did on health decision-making supports for Asian American undergrad students. I had help from my faculty advisor, Dr. Hannah Mercier, to per conducting this survey. So a bit of background on my survey. So in college, this is like usually the first time young students, must the first time they'll have the chance to like, be independent. And this is also when they have to start taking like greater ownership of their own health and health decisions. And like, however, many students are unequipped to like discern their own health information and like the validity of this information. And they usually end up relying on their parents, guardians, and other providers for this health information. And previous studies have mostly focused on decisions centered around specific conditions such as depression, mental health, and like vaccinations. And furthermore, Asian and Pacific Islanders also have been reported to have the lowest health literacy levels when compared to other races and ethnicities. And as an Asian American myself, I feel like it's important to understand and support this process in Asian and Asian American undergrad students, because at Stony Brook University, like among the residents, they make up about 46% of the residents, and nationally, they're about like 7% of the college students in the US. So the aim of my study was to determine the general health decision-making processes among Asian American undergrad students, and if there are any similarities or differences in the ways they make their decisions. So for methods, I made a online survey that was about like 5 to 15 minutes and it was hosted on Qualtrics. And the questions included like things that asked respondents about the criteria they use to evaluate an information source's trustworthiness. I also asked about the environmental factors or people that influence their choices when it comes to health. And I also asked about participant demographics as like a sort of screening to ensure that like, they actually fit the demographic that I was looking for, in which the eligibility was determined by if the participant was older than 18 and if they were Asian American undergrad students enrolled in American university. And recruitment was done through snowball sampling. So I was able to receive a total of 47 surveys. However, only 40 were eligible for analysis, as one was younger than 18 and two had ineligible race ethnicities, and one was not undergrad students, and 3 of them were just blank surveys. So as you can see on here, the graph, it says of the surveys, 57.5% were actually 18 to 19 years old, and the rest were like 20 and older. So for results, most respondents actually reported awareness that some health information they read may be false. However, the majority did not claim to do not really check much for credibility, as you can see in figure number 2 here. The dark purple is like indicating that, oh, they don't check it, while like the second dark purple shows that they do check it sometimes. However, when they did, information recency and author credentials were what they considered first. If this is like the date of the site creation and like the author's credential, it shows that like some of the time they check it and like only a few check it all the time. Other criteria that like they participants told me that they checked that I didn't list personally was that they checked if it was .org or .com, or like if the website was trying to sell them something, or also like how well known the website is, like its reputation, and how authentic, professional, organized the site looks. So for online sources, so when I asked about what sources they would go to first, 73.8% reported that they would go to Google first, with WebMD as second, as you can see in figure number 1 here. So I asked them to rank the sources and like which they would go to first, second, third, fourth, and Google is like the darkest right up here, with like WebMD is this orangey down here. And following that, when I asked about like people that they would go to, or other environmental sources, 43% reported that they go to health professionals first, with their parents at a 27%. You can see that in figure 3 here, where almost half of them said they would like go to health professional first for like information. And when I asked them about how often they would verify the information given to them by others, or like given to them by these people, 42% that they would compare the information that their parents gave them to what others tell them, or like other sources they find, while surprisingly, oh, sorry, was surprisingly, when I asked them about like how often they were verified the information given to them by health professionals, it was more split between some saying that, oh, they would compare to other sources, while like some also a lot of them said that they actually wouldn't compare to other sources and they would just like take it at word value. And when I asked about how much time the respondents spent researching health information, majority of them said that they would spend 6 to 15 minutes researching, while at 52%, while 21% said they spent 1 to 5 minutes, and the rest spent more than 15 minutes, and some even spent over 30 minutes researching. Also surprisingly, that none of the respondents said that they never looked at information. At least like everyone who responded said they will at least spend a few minutes researching information. So in order to compare like the responses to each other, I divided the participants' responses into two groups, two age groups, so 18, 19 versus 20 plus. As you can see in the age breakdown, like almost half of them were like 18, 19, and the other half is like 20 plus. So I thought that would make it a little more even. And when I performed t-test analysis on their responses to each question, I found out that there was no differences between age groups on time spent researching health information and how often they noticed what they read was false. And there was also no significant difference between the ways like they determine criteria and like the. So in contrast with previous research where I found that most college students seem to go to family first when it comes to like researching health. Asian American students seem to value advice from health professionals over family, which was a little surprising to me, as I know that Asian culture is really like family oriented. So I thought maybe they would be more like relying on like what their family would tell them. However, it does seem like they're still more likely to consult secondary sources over government sponsored ones. And results do show that there is some awareness for checking credibility of sources, as like they are aware that not all information given to them may be completely true. And they are aware that there may be potential bias in the advice given, so they do double check with other sources, but not all the time. So while Asian American students seem to make some surface level attempts at health decision making, I believe that interventions are still recommended to support these search behaviors, as well as maybe programs to raise awareness or source credibility and trustworthiness. Some limitations to the study do include that I did have a small sample population and that there may be potential bias due to the recruitment method. So I think that future studies could scale up the survey pool to other universities or online groups to help compete with this bias. And in the future, maybe like we can focus on creating tools that may further help support independence with informed health decision making. And that's it. Thank you. If you guys have any questions.
So I'm curious, you kind of led into this very nicely, but if we're thinking about using this data to identify points of intervention, what would be the one aspect or the one area that you would like to see a change in behavior to kind of increase that information literacy for this population? Either kind of what's the lowest hanging fruit or what would have that biggest impact?
I think the one with the biggest impact would be like checking credibility of sources that they access, because right now, like, we're in the age of technology, like everyone always like online looking for stuff, and that it's like online is where like information is most readily available. So like as I said before, in figure 2, it seems like only some of the people, like small percentage of the respondents, seem to actually check credibility of the websites that they look at. So like I believe like if we try to like aim at raising awareness of like how students who are looking for information can like check for credibility, it might help in like help them like get more accurate information.
Thank you.
Thank you.
Thank you, Joyce. Wonderful presentation. Looks like I have Olivia and Alicia presenting now. Perfect. And they will be presenting on parent satisfaction with speech language pathology services provided via teletherapy. So if you guys want to share, go for it.
Okay, can you guys see my screen?
Yeah, can you put it in slide? There we go. Perfect.
Good, okay.
All right, I'm going to start the timer.
Okay, so like you mentioned, I'm Olivia Poulin and I'm here with Alicia Marine. We also had some other research partners, which were Janet Ifa, Damian Nolan, Amanda Owens, Annabelle Rosenzweig, and then we also had our mentors, Dr. Renee Fabus and Dr. Dominic Fortuno. And we are Stony Brook graduate students in the speech language pathology department. So our research study was on parent satisfaction with speech language pathology services provided via teletherapy. And just a little bit of an introduction, as all of us, or most of us know, a new strain of the coronavirus, COVID-19, had spread rapidly across the world in 2019, leading to new restrictions affecting therapeutic services. And we saw an exponential growth of teletherapy services in a variety of health-related fields. And speech language pathologists were among those professionals using teletherapy. And we had defined teletherapy as telephone, video conferencing, mobile devices, or emails to deliver health and medical services to treat and evaluate their patients. So current studies, when we looked into the research, had investigated the effectiveness and perception of telehealth among SLP services, and they showed mixed results. And the top 3 disadvantages to telehealth that we had found, according to a survey that was disseminated to 259 SLPs in a variety of employment settings across the country, were issues with connectivity, lack of family support or appropriate environment, and client behaviors. So we really wanted to look into identifying the strengths and weaknesses of using speech language pathology teletherapy services, but from the parent and caregiver perspective. So we looked at it on Long Island, which led to our research question, which was which implementation factors contributed significantly to parent and caregiver satisfaction with speech language pathology teletherapy for children ages 5 to 11 from the onset of the COVID-19 pandemic through the present on Long Island. And we really felt that this research would be useful in identifying implementation factors that should be used in future teletherapy services and other factors that need to be addressed in order to deliver these services effectively. And for our method, we did an 18-question mixed survey, which was created and disseminated via Qualtrics. And our participants were recruited through convenience and snowball sampling. So we put it out on Facebook groups that had either SLPs or parents or caregivers of children who were getting services. We did word of mouth as well as flyer distribution at different clinical sites and private practices near us. And we did get a total of 18 responses, and 4 true responses remained after we went through all the screenings. And the survey contained both quantitative and qualitative questions, including a screening section and general questions regarding parent satisfaction with teletherapy implementation. So again, our participants were parents or caregivers of children age 5 to 11, and we chose 5 to 11 because that is elementary school aged at the time. And they had to have received services in person prior to the COVID-19 pandemic, as well as virtually during the pandemic, and they had to reside on Long Island. So we were really looking at variables like service frequency, training, and accessibility, and how they affected satisfaction. And you could see on our poster, this is just an example of some of the Likert questions that we used. So we had them rate their level of agreement with the following statement provided on a scale of 1 to 7, with 7 being the highest level of agreement. And just some examples of questions we used were my child's speech language pathologist was accessible via teletherapy, or my child's SLP provided adequate training for the use of teletherapy software. And now I'll give it over to Alicia to finish.
Thank you, Olivia. So getting into our results, following data cleaning and analysis by our AHI student, Jeanette, we found that there were positive correlations between satisfaction and parents' perception of involvement. So that was a really crucial one for us because it's so important for parents to feel involved in the telehealth services that their child is receiving, and that perceived involvement leads to increased satisfaction with these services. So as telehealth providers, we want to be making sure that we're doing everything we can to make these parents feel as involved as possible with these services. Additionally, we found positive correlations between accessibility and the perception that services were equivalent to that which was received in person. So the accessibility of the SLP via telehealth really helped these parents feel that, yes, the services I'm receiving via telehealth are equivalent to that which my child would have received had they been going in person. So again, that's a really important factor for us as potential telehealth providers in the future to consider, that we really want to make ourselves accessible to our clients via telehealth. And then getting into negative correlations, we found negative correlations between satisfaction and pricing. So, with pricing, as it becomes more expensive, satisfaction, can sort of suffer a little bit. And then again, with accessibility and benefit. So when the SLP was not perceived to be as accessible, the perceived benefit that the child received from these services also went down. So that negatively impacts satisfaction. And so we also found that there was high satisfaction during certain periods, which really showed us that, as we expected, parents were more satisfied with services delivered in person rather than that received via telehealth. So this is important data for us to take into consideration as we continue to examine these implementation factors for providing telehealth. And then accessible teletherapy services were really positively influencing parent and caregiver satisfaction. So that accessibility was a big one. If the SLP was perceived to be accessible, parents were very satisfied, and then it was the opposite if the SLP was not perceived to be as accessible. So this is a really important factor for not only SLPs, but service providers via telehealth in general to really take into consideration. These two bar graphs just show an example of two questions from our survey and the distribution of responses. So I know it's kind of small and it's hard to see here, but along the bottom you can see the distribution of the Likert scale responses from 1 to 7, with 7 being the highest level of satisfaction, and the number of participant responses, which of course we only had 4. So Olivia already, gave you guys some samples of some of our questions, so I won't get into that too much. I'm going to jump to conclusions. So we were able to conclude, based on this research, that parent and caregiver satisfaction was significantly different, again, when services were provided at different phases of the pandemic. So people generally still prefer that familiar feeling of going in person to receive these services. So we really need to work to make telehealth accessible and functional and beneficial and, positively perceived by our patients. And then another one, that parent caregiver satisfaction was also positively influenced by these strong feelings of involvement again. So accessibility and parent involvement are two really big ones that we came out with based on this research, that these are implementation factors that are really important for providers to consider when implementing telehealth and, in order to facilitate that satisfaction that we all want to see with these services, right? So for clinical implications, as the role of technology in this field and other fields inevitably increases, there's only a higher and higher potential for more and more services to be delivered via telehealth in this manner. And so examining these implementation factors that positively influence satisfaction is going to continue to be important. So we hope that this research serves as a base for continued research in this area. And then again, if and when implementation of teletherapy becomes essential, again, we really need to take these factors, especially accessibility and perceived involvement, into consideration in order to support clients and their families. And then just for our limitations of this study, again, as we've mentioned, we did have limited responses for this study. We had some pretty specific criteria, and we were really focusing on the area of Long Island. So this, I think, really limited our ability to get the amount of responses that we were looking for. Again, we only had 4. And then the survey window, possibly if we were able to increase that a little bit, we might have gotten some more participants in our study. but we did have a relatively narrow survey window. And again, that location of just focusing on Long Island kind of inhibited us in getting the responses that we wanted. But we did really want to look at Long Island specifically for this study. And I'm seeing that I'm running out of time, so I'm going to stop now. And again, we want to acknowledge Dr. Favis and Dr. Fortuno for all of their help and our AHI student, Janath. So thank you. And of course, if there's any questions, please.
I was gonna say, I don't know if we have time for questions, Chris.
We
let
do.
me know
Yeah,
if you
sorry.
want.
We do. We only have one more presenter in 15 minutes, so go ahead.
Okay,
great.
perfect. One of the things that I think really stuck out is that telehealth isn't going anywhere, right? So now that we've kind of made the transition into that form of providing therapies, I think the idea that it is more accessible for families, right? It might be a bit more convenient. Regardless, it's going to be around. It's, hopefully going to be an option and help us provide better care. I think what I'm really interested in is what you think about those subcomponents of accessibility being. Is it availability of appointments? Is it response time when parents are reaching out with questions? Kind of what is it that's creating accessibility in a sense?
Exactly. Accessibility is such a complex factor to really look into because, like you said, there's so many things that go into it. I know that we were kind of thinking about accessibility of that SLP, whether it be via email, phone, and again, availability of appointments. But again, when we consider accessibility as well, we have to think about access in terms of technology, Wi-Fi, just the resources in general. Like, does this family have a computer? How are they, going to access these services? So yeah. And Olivia, if there's anything you want to add. I think yeah.
Pretty much what you said. Yeah, like definitely looking at, all the different variables of accessibility. There definitely is a lot there.
Thank you.
Thank you.
Thank you, Alicia and Olivia. And we have one more presenter. And I apologize if I pronounce your name, Nasher White from Brockport.
Yes, it's pronounced Nashere, but you were close.
Okay, well, correct me. I want to say it correctly.
Nashere White.
Nashere, thank you very much. And Nashere will be presenting on impacts of financial stress on college students' subjective well-being and academic performance during the COVID pandemic. So Nashere, if you want to share your screen, go for it.
Okay. Share screen. Okay. So for my research, I explored the qualitative inquiry on how COVID-19 impacted college students' ability and their mental health due to their excessive financial support that either they would rely on from school, so the financial aid refund, or from family support, or from putting themselves through school by working. So some of the background that was identified for some of the research that I found was that a lot of the financial stress that college students perceive comes from the financial stress from tuition fees, insufficient familial support, and other challenges that brought upon COVID-19, such as the lockdown, which kind of canceled a lot of the work study positions on campus jobs and everything like that, or any local jobs within the vicinity, due to a lot of places having to close their doors if they weren't considered primary first responders. And then outside of that, a lot of other studies kind of talked about the manifestation of mental health from financial strain. So that can look like added anxiety, stress, and depressive symptoms on top of the normal expected, which college students experience during their education. And then some other challenges are kind of balancing that social life. So kind of having their school life, the social life balance along with working, trying to see how that fits in and how much more additive stress is kind of perceived for college students. So my objective ideally was to find the impact of financial strain on the well-being and academic performance of college students primarily I use students of SUNY Brockport. So the study included majority of student Brockport students and a few other students outside of SUNY Brockport's campus. And it was done via social media for the recruitment, and the interviews were conducted over Zoom. So this chart in the middle is ideally categorizing the main themes that arise within the study. And most of the college students, the three main themes that kind of arise was the need for financial literacy. So a lot of the college students that come from middle income households, however, they didn't have as much knowledge towards how to manage their finances, where to look for their credit report, and all those other things associated with financial wellness. And another theme that came up is majority of the college students depended upon financial aid and familial support. So 11% depended on financial aid, 23% depending upon their family support, and majority of 64% did provide most of their financial support through working. And then as for mental health outcomes, 64% of the students reported financial distress contribute to their academic performance in a poor manner. So most of them would say that they didn't get enough sleep, they were not able to focus, they had increased stress and anxiety, and they were just anxious due to the implementations of COVID-19 and kind of how that changed everybody's lifestyle for that time frame. So in conclusion, my study revealed that COVID-19 has heightened the anxiety and stress affecting students' financial management and academic duties, which what I would like to see if we kind of continue with this study is to explore more of the association between their perceived financial stress and their student quality of life. So kind of digging deeper into what those students do as a means of their financial stress, like how do they manage their finances, where do they delegate their money, are there certain areas that maybe they need to focus on more instead of other areas. And that's pretty much it that I have for right now. My apologies for running through it so quickly. Are there any questions or concerns?
No concerns. This was fantastic, but I do have a question.
Yeah.
I know that you didn't report any of the data here, but I was wondering if you just played around with the numbers at all and you looked for some of the interactions. So in particular, I'm interested if you noticed that the students that reported they were self-sustaining financially throughout their education were also the ones that tended to be more distressed or kind of had that financial distress impacting their academic performance.
Yeah, so that is not displayed there. So yeah, so a lot of the students that did typically work themselves are the main ones that kind of pulled that poor academic performance, just because it's kind of hard for them to delegate both of going through school full time during the COVID lockdown and how that transition from in-person to online kind of changed their mental capacity to kind of focus on school while also trying to support themselves. So a lot of them kind of had that kind of correlation.
Yeah, and so I noticed that one of the things that was suggested was increasing financial literacy programs.
Yeah.
Thinking about that interaction, that doesn't really solve that piece there. So what is something that you think would be a great suggestion to help improve the mental health outcomes for these students that are independently funding themselves through the program? If there are any kind of supports you might suggest, things along those lines.
Yeah, so the reason I mentioned more of the financial literacy aspect, because for some of the students that reported their finances were pressing them, they were allocating their resources towards kind of self-care kind of thing. So they were buying more things, they're spending more time shopping, or they were buying more food to kind of cope with the stress. So it's more of the managing their money that they were worried about. So that's how I was saying the financial literacy of how to create a budget that can work for what you need in your life, but also kind of keeping to that set schedule where you're not overspending in one area. So that's why I tied more to the financial literacy aspect.
Fantastic. And to be clear, I think we all could benefit for more financial literacy, right? I think our undergraduates and even at the faculty level, there are times I would like more education on this. But I think that's a really nice way of integrating those pieces. So thinking about, I feel like it's, you know, pretty popular now too. We were like, oh, I did this. I have to go get myself a little treat. And if that's, you know, the Starbucks or whatever it is, but kind of thinking about that within the broader scope of things. Yeah, no, I think that's a really nice connection. Thank you.
Thank you. Are there any other questions? Okay, well, thank you guys for listening to my presentation. My apologies for running late. I had a lot of technical difficulties.
No problem. Thank you, everybody, for joining us today.